Hello, everyone. It's the end of the week, but it's not the end of the world, so it must be time for the V.A.C. Roundtable, and this one's number 62. We're joined by Nurse Nique Pichette, who has, of course, been in the cannabis scene for a bit, but it was also a Marine. So she is one of us, and as we are looking to continue our discussions with people whom we respect and view in a high light here in the cannabis community. We've had talks with other educated nurses and doctors, and we want to continue that discussion today. And so we'd like to thank Nurse Nique for joining us and taking the time as we get things underway. So with that, we'll go directly into our speaker view. And right off the the bat, Nurse Nique, our first question is kind of a multi-layer question, but how did you first come to cannabis? How old were you when you first heard of it? Did you use it? And what made you choose that direction?
So I first tried cannabis when I was 16. I didn't like it very much. It made me paranoid. It wasn't something that I had much pleasure in. I couldn't understand why people used it. And I grew up with it being stigmatized as a street drug. And fast forward to 43 and my second diagnosis of breast cancer, I found that I was allergic to the antiemetics, which are the medications that we use for the nausea and symptoms from pharmaceuticals. And I was also writing a blog called Breast Cancer and Me. And I started to have many people start to follow me and send me messages that I needed to try cannabis. So at the time, I was a director of nursing operations in an assisted living, and I was afraid I was going to lose my nursing license, and I was afraid that the rest of my life was going to fall apart. And I saw a picture of my son, and it was him and he was taking me to radiation, and I was extremely emaciated. And I was 111 pounds, and I was a recovering anorexic. And at my lowest weight, I was 93. And when I saw that picture, that was like the wow factor, because I was like, if I look like this at 111 pounds, what did I look like at 93 pounds? And I reached out to Stephen Plasek. He's from New Jersey. He was like the biggest, advocate, messaging me articles constantly. And at the time I was living in Rhode Island that had a medical program. This was 2013. So I went through the steps to get my medical card, and I started using cannabis medicinally. And my caregiver was actually an Army veteran. His name was Chapman Dickerson, and he came to my house with a care package, and he sat with me, and he had edibles and tinctures, and he had lemonade, and he had flour. I mean, any way you could use cannabis, he had in this care package. And he said, just try what you want, see how it makes you feel. Just do a little bit at a time, and I'm here if you need anything. And today he is the owner of V.A.C in Fairhaven, Massachusetts, one of the top ranked dispensaries here in Massachusetts. So I was blessed at many levels.
That's quite a journey. Thank you for sharing that with us. Next up will be Council Member Wade Laughter for our next question.
Is he muted?
Just 1 second, yes.
There we go. Now let's see if I can get back to the chat. basically the question, Nique, first of all, thank you for joining us this afternoon. And I'm still sorting out how to do this on my phone. And my question is, as a veteran and as a survivor of cancer treatment yourself, can you discuss how cannabis has played a part in that? And please correct me if I left out part of that question, because again, I can't seem to get my phone to cooperate here. Anyway, you get the gist of the question, I think, and you might even have a copy of it, dear. So thank you so much.
So would you like me to repeat the question?
Go ahead.
So did your military background help you confront cancer and the debilitating treatment for the same? And the answer for that is absolutely. I'm a veteran of the United States Marine Corps, and I chose the Marine Corps because I grew up in a very male chauvinistic household, and I wanted the branch that was supposedly the hardest boot camp. And my dad was Air Force, World War II and Korea. And so I was like, okay, he's Air Force, I'm going Marine Corps, and my brothers never served. So that was the background of why I chose the Marine Corps. And physically, boot camp, I excelled extremely because I prepared physically, but I didn't know how to prepare mentally. And by the end of my 13 weeks, I was mentally prepared, not as much as I needed to be, but at least for that time in my life, the Marine Corps broke me down emotionally and mentally, and I graduated as they picked us all back up and sent us to our duty station. So the mindset that I had from the military and the Marine Corps was one of never giving up, never surrendering, and by all means, kill or be killed. So that's what my attitude was when I received my second diagnosis with breast cancer. And I was determined that I was going to give it my best fight and take some of those psychological and physical lessons that I was taught through boot camp on this next journey, another war, if you want to say, that I had to put myself through.
Thank you for that. And hoorah, Marine. We don't get many female Marines out there, although we do have a member who is, but not many that make their way in, the level of nursing and doctorates that you have necessarily attained. So add a girl, thank you very much for sharing your story and your trials and tribulations. I think all of us in the military can relate to that. Next up will be Councilmember Alex Popoff. Councilmember Popoff.
Thank you, Etienne, and thanks for joining us, Nique. The question I have is, you're active in bodybuilding. Was this part of your return to a healthy overall physiological condition?
So I actually was competing in bodybuilding before I joined the Marine Corps. And that's why I said I joined when I was 21. So my recruiter told me that I could be a bodybuilder in the Marine Corps, and that was not real. So, but that's okay, because that's why I said the physical training of the Marine Corps actually was easy for me because I was so conditioned. But I did use bodybuilding and cannabis to get me through my second battle with breast cancer. I actually got a personal trainer, and I made sure that during my chemotherapy, so my chemotherapy was every 2 weeks, so it was every other week. So I had a trainer that I met at the gym once a week, and the rest of the time I trained by myself. And I made sure that I definitely made sure that he knew when my off week was because I felt better, and he knew when it was a chemo week because I didn't feel too good. But it gave me again that mindset and that determination that like I just had to do this, and he helped to push me through, and again have the determination and the resilience that I needed, along with cannabis. So I was actually advocating for cannabis and bodybuilding in 2015, and actually started a clothing line called Nique. And it was too soon. People didn't like accept it and understand it. And I was really advocating for cannabis over steroids in the world of bodybuilding. So
You were a little bit ahead of your time in that sense. And hey, it's part of being a trailblazer, right? Is sometimes being ahead of your time, and time and expectations of society don't always meet. However, just to kind of follow up there, because I know how roid ridden the industry is, did you actively engage people regarding their steroid use and try to use cannabis? Because I'm also aware of, people like Arnold Schwarzenegger and others that decided to imbibe on cannabis because they didn't get the calories from drinking, which of course alcohol does, no matter which way you imbibe alcohol. So what was the reactions to people when you engaged in that? That must have been challenging.
So I was still a little nervous about being like really loud about it, but I would like blog and post pictures. And to this day, I haven't called out anybody in the bodybuilding industry about, hey, you use steroids, what's wrong with me using cannabis? It's still quite hush hush. It's still something that like it's known, but it's not discussed. And for some reason, it's okay in that sport. So again, I just tried to kind of, I tried to just go forward in my own healing. And I actually connected with Marvin Washington, who's an NFL player who's in the space that I met through the Cannabis Nurses Network. And when I was competing in California in 2018, I was also marketing his CBD water and some of his products. So I would be at the gym and I would have his products and stuff like that, and Nature Nurses products, when so I could show what I was using as my dietary supplements, if you would say.
Thank you for that. Our next question will be from Councilmember Michael Krawitz.
Thanks, Etienne. It's so nice to meet you, Nurse Nique. I wanted to say, well, first of all, let me say I was able to not join the same service rank, branch as my dad, and yet somehow still stay in the Air Force. My dad was Army Air Corps, and I joined the Air Force. So,
yes, my dad started Army Air Corps as well.
So my question it really revolves around, and we found it very interesting, your background, especially being a psychiatric nurse. We have, Mary Lynn, who's, an addictions nurse, and certainly addictions is in that camp, so she can sort of translate for us sometimes. And then we had some great psychiatrists that we worked with, Dr. Mikaria comes to mind as one of our mentors. I believe you may be the first psychiatric nurse that we've actually been able to talk to. So anyway, really great to meet you, and so happy to do so. We really focused in on your tool that you said you created. The question was, please tell us about this tool and how you differentiate the tool that separates inappropriate from appropriate cannabis use.
So it's not totally complete yet. I did my dissertation for my doctorate, and I just graduated in May. And that pilot study consisted of 21 questions that take into consideration the DSM-5, which is like the diagnostic Bible for psychiatric conditions. It took in consideration the Q-R, which is the gold standard that they use right now to diagnose cannabis use disorder. And what people don't understand is the Q-R, cannabis use disorder inventory, is stems from the audit, which is the alcohol use disorder inventory tool. So how can you separate alcohol and cannabis using pretty much the same tool and some of the same questions to come to this diagnosis? So the first part of my dissertation and my pilot study went to healthcare providers and asked healthcare providers to review these 21 questions to see if they thought in their professional experience that the questions asked could had a total look at cannabis use and could appropriately separate cannabis use for inappropriate and appropriate use. Was it a full assessment? And we came to find out that the majority of healthcare providers felt that it was the questions came up with a full assessment of cannabis use, and they felt that it would be appropriate in separating abuse versus appropriate use. So I'm working with Olin Neuropsychiatry Center right now with Dr. Perlson. I did submit a grant application for phase 2 in which we did not get accepted for, but the IRB came back and said, if you make a few of these tweaks to this and resubmit, that we feel that you're definitely onto something that we want to move forward with. So what I'm going to do is I'm working actually as we speak on the IRB application with Dr. Perlson and Nurse Heather and a couple of other people in the committee, and we're going to be pushing that through the IRB. But the thing is I'm trying to do it with no money. I'm trying to just say, I don't need your money. I don't need a grant. I'm just need to push this survey through at least 250 people that use cannabis, that they've used cannabis at least once in the past year. I need 250 people to answer these questions. Then once we get the data from those questions, we're going to look at the data that comes in, look at these 21 questions, and then come up with the tool that will actually be able to separate appropriate versus inappropriate use. And that's where we're at right now.
Thank you for that. Next up will be Council Member Nate Landau. Council Member Landau.
Hi, thank you so much for joining us. My question, sorry, there's a train going by. My question is, the VA has mislabeled many military veterans as having cannabis use disorder or COD based on simply on the failed drug test. How should we approach correcting this problem? Thank you.
So this is why I did this study, because I was a night supervisor in a psychiatric hospital in Massachusetts during COVID. We were very short-staffed and I worked the floors a lot, and I was starting to see these diagnoses coming in more and more of cannabis use disorder. So during that time, there was a CEU article for credits for nurses and healthcare professionals that came out on cannabis, cannabis knowledge. Mary Lynn, it was by Eloise and somebody else. They wrote that article for ANA. I asked my director of nursing if I could put it at all the nurses stations. She said yes. I was trying to educate everyone about cannabis and cannabinoid therapeutics in the endocannabinoid system. And within less than a week, somebody anonymously emailed the director, said, you better check your night supervisor. She might be coming to work high. And she has a clique of people that like cannabis. And I had to take all of those articles out of the nurses station, but it's okay because it just lit a fire underneath me. And I said, okay, people are coming in positive for cannabis. They're getting diagnosed with cannabis use disorder. The doctors don't know anything about cannabis or the endocannabinoid system. The nurse practitioners don't know anything about cannabis or the endocannabinoid system. how are they getting diagnosed with cannabis use disorder? Why are they getting diagnosed with cannabis use disorder? And I can't even talk to them about how they use cannabis, why they use cannabis, and when did they use cannabis last? So that's when I said, okay, I started to dig deeper in the charts and I started to have these conversations. And again, I was shut down because I don't think everybody also realizes there's also an ICD-10 code for cannabis use disorder, which is a billing code for insurance companies to get your money from your insurance. So therefore, if you're positive for THC and they diagnose you with cannabis use disorder, now they can bill your insurance company and then they can get paid for serving you. So it's this crazy didactic that's like, it was making me so angry because not everybody knows this about me, but the only reason that I went back to school to collect all these initials is because I'm a patient first. And when you're a patient, people don't listen to you. And when you have a psych history, people really don't listen to you. So because I have a psychiatric history and because I'm a patient, I wanted to try to find a loophole, and that loophole was to get my education. So I had to come in and find all this stuff from the patient's perspective and then try to figure out how I could flip this and say, okay, I'm going to do a study on cannabis use disorder and how we effectively diagnose it. But what I'm really trying to say is we're inappropriately diagnosing this. But those of you who know research, I found out the hard way, you have to make it look like you believe in cannabis use disorder to get the results that you want.
That's unfortunately been something we have realized for decades from researchers, as I have come from being a veteran to a patient advocate. Because back, Nurse Nique, for me, I was before cannabis use disorder became a thing. It was known drug user in the VA system, and I was classified as that and physically removed from multiple VA facilities just for even mentioning cannabis use. So this has been an ongoing problem our veterans have been dealing with for decades. I had to literally work with people to change the laws to finally arrive at my disability rating that I just got a few weeks ago at 100%. So I think that in my opinion, what we have seen is because there's such limited knowledge around cannabis at the doctor's level, we ourselves at Berkeley Patients Group, we have actually hosted doctors, pulmonary surgeons to actually educate them on cannabis because there's no education, ongoing credits, etc., specifically, dealing with and around, medical cannabis. So we've had to educate them. However, they still want to put us veterans into boxes, and there's no box currently for a veteran using cannabis medically, in their opinion. We Asian went as far as going to a FOIA request from the United States government to get all the information, of which this week they came back and told us they have no data. And it's really funny because the other person on this call, Michael Krowitz, was the person who instated that into the VA back in 2010. So for the past 13 years, our government's telling us they're not even giving us or storing the data on top of, again, because you have cannabis, so you have to fit into this, you have cannabis use disorder. It's the same problem that we're seeing if somebody is having nausea and they state they have cannabis, people are saying that they have cannabis hyperemesis, right? So that's another issue of where we have kind of two low-hanging fruit that either doctors or nurses are going off of because of their ignorance, willful ignorance, as well as just the lack of knowledge around cannabis, but at the same time, the institutional respect to give a space for, hi, I'm a patient and a veteran, I use cannabis and it works for me. Can we document this and understand why? So I don't really have a point as much as I just to bubble up the frustration that you're seeing as a nurse practitioner and we as patients have been experiencing over the decades. There's still a disconnect that we've been coming to you as doctors and nurses trying to, appeal. And thankfully there are nurses, like you, Marilyn Mathery, and others that we have hosted that are taking it to the curricula level and educating doctors and nurses at a level that they can comprehend and respect and take forward. And then we saw just this week with the nurses associations coming out and imploring that, cannabis is medicine and institutionalizing it to a level that hopefully we'll see some penetration of education.
I do just want to say is that I am not a nurse practitioner. Okay, so I can't prescribe, I can't do medical cards. I do have my doctorate in nursing, but it's in nursing leadership and I work in research. So I don't want people to get confused or think that I'm like speaking outside of my scope of practice. So I just wanted to say that. The other piece that I wanted to say is that for veterans, if you can get your hand on a DSM-5, which is the Bible for psychiatry, okay? Because something that we do not talk about, the doctors don't talk about, the psychiatrists don't talk about, and I wish I had the exact page, but within cannabis use disorder diagnosis, which is in the DSM-5, the criteria, it says, whether or not cannabis is being used for legitimate medical reasons may also affect diagnosis. When a substance is taken as indicated for a medical condition, symptoms of tolerance and withdrawal will naturally occur and should not be used as the primary criteria for determining a diagnosis of substance use disorder. Although medical use of cannabis remains controversial and equivocal, use for medical circumstances should be considered when a diagnosis is being made. And that's actually on page 511 and 512 in the DSM-5, which you can bring to your psychiatrist and have them open up to that page.
Great. Thank you for that. That will be very helpful for people and myself. Councilmember Crowell, says a follow-up. Councilmember?
Thank you so much. I so appreciate your insights and your work. Interesting. You might find this of interest. The medical cannabis the medical cannabis policy of the Veterans Department of Veterans Affairs, Veterans Health Administration that Etienne was talking about. That came about as a result of a question that was almost right at the heart of your work, right at the middle of what you're talking about. Because what we did was, we had all these veterans that were using cannabis under doctor's orders per state laws. It wasn't technically legal under federal law, but they were using it under doctor's orders in their treatment plan and was being accepted under at least some legal regimen at the state level. And the question became very straightforward for the, we actually sent the question to the general counsel of the VA because everyone was presenting this to us as a legal question, but the question was then forwarded over by the general counsel to the undersecretary of health. And the question was simply, if you're a veteran and you're using cannabis per your doctor's orders, having good success at relieving your symptoms as per your treatment plan under a state legal sanctioned program, should you be punished inside the VA facility? Should you be sanctioned? And the question came back really quite beautiful. The letter was actually quite beautiful from Undersecretary Petzel, who said that, it should be treated like any other medicine. And, certainly shouldn't be any special criteria based on the fact that it's marijuana. It should be under that circumstance treated like any other medication. So I don't say this very often, but I think your work is important. I really do. And thank you for it. But I have one other point. I wanted to just elaborate on something you were talking about because you just reminded me of it. And that is when you have such a broad sweeping brush to put people in a cannabis use disorder category, to label them that way with such a broad brush, that we usually look at it from the injustice to the individual and how that screws up the person and how it can stigmatize you and everything, and that's legitimately our focus. But it also screws up the data for everybody else. I mean, if you really want to know how many people are actually addicted to marijuana, you have no idea. There's absolutely no way to tell from the current statistics and the current data and the current experts in the field. And I would imagine, throwing so many people at the wall makes it almost impossible for someone that really does suffer, bless their soul, suffer from abuse disorder of cannabis, probably can't find help because of the fact that there's so many people in their way that have been mandated by the courts or whatever else, into drug treatment because of such just abusive labeling. So just again, thank you so much for your work. And while I'm talking so long, I'll add one more thing. Congrats to all nurses for the ANA putting the cannabis nurses in under the tent.
I thank you for that insight and some of those questions. And I do want to say, one of the things is Marcy Cooper, one of the cannabis nurses that was my preceptor during my school, sent me today that was on a news channel. She's in Colorado, and she sent me a screenshot of her television, and I wanted to share this with everyone tonight. And this news, Good Morning America, actually. Signs of cannabis use disorder. And this was what they had plastered across the screen of the television. Using more cannabis than intended, difficulty controlling use, problems at work, school, or home, needing more to experience a high. And then the second screen that Marcy sent to me that was on Good Morning America was another full screen on the television. Heart health and cannabis study. People with cannabis use disorder have a 60% chance risk of developing cardiovascular complications. I just want to say, this is something that I'm seeing as a psychiatric nurse still working at the bedside. And I just had this conversation with the psychiatrist on the unit. I had a man the other day, this is a true live case study. He was in his early 60s. He was on the adult inpatient unit, and they were getting him ready to start ECT for his suicidality and his depression. His blood pressure was through the roof, like 180/105. He reports that he never had any blood pressure issues that he knew of. I went to his chart, I looked, and he was positive for THC. But the other thing is that he had ethanol in his urine. So I went back to talk to him and I said, look, are you using alcohol? Are you possibly withdrawing from alcohol? He said, Nique, I don't drink. I don't know why there's ethanol in my urine. I don't know. The man seemed to be legit. I'm not going to question him. My second piece was, I see that you're positive for THC. How much cannabis do you use? He said, I smoke at least 2 joints a day. I've done it for the past 40 years. What these healthcare providers, nurses, psychiatrists, and the mental health are not looking at is, if you're on an antihypertensive, a pharmaceutical, and you run out of your medicine, you can't afford it, within a few days, you're going to have rebound hypertension. Your blood pressure is going to go through the roof. Cannabis is an antihypertensive. I'm seeing it in the research center as I'm actively dosing live patients with cannabis. It's right there. Within 5 to 10 minutes, you can see the changes in their heart rate and in their blood pressure. By the time I saw this man, he had been in the hospital for 3 or 4 days. He had no cannabis. I went to his psychiatrist and I said, look, I know you probably don't want to hear this, but do you think his blood pressure changes could have anything to do with his cannabis use? He looked at me and he said, oh, you mean like cannabis withdrawal? The only thing they get with cannabis withdrawal is agitation and anxiety. I said, no, that's really not true. There's other changes that are taking place, and we have to see if they're using it appropriately or inappropriately. The psychiatrist looked at me and said, appropriate cannabis use? I don't think so. I said, no, cannabis is being used even as simply for PTSD. He goes, I need to go now. And that was the conversation that I had with the psychiatrist. But I brought it back to Dr. Perlson. I brought it back to the research lab. And I said, Dr. Perlson, look at this is what I'm seeing next door at the hospital. We need to do something to help patients that are actively medically withdrawing from cannabis, not in a bad way, like you do with opiates and alcohol, you can die, but just to help them mitigate that time spent in the hospital where they're not allowing them to use their cannabis. But we need to find a way to get the education. Nurses don't, when you tell them that cannabis, oh yeah, smoking a joint, right? I thought a nurse was gonna fall off the chair the other day when I told her there's patches and suppositories and inhalers and capsules, and they just think smoking a joint and that's it. So I'm trying to like glide on this fence and try to like, you know, get as deep in as I can and find, like Dr. Perlson said, somebody that's going to be sympathetic to my cause that's in the psychiatric hospital, that I can get that segue to then bring them to Dr. Perlson, because they're going to respect Dr. Perlson because he's been doing human cannabis studies since 2014. But it's sad, it's happening. And this is why the education and the knowledge is so important. You don't need a doctorate to do this. You just need to find the information, and you need to have reliable sources of people that are going to go against the grain. And that's why I do this. Yes, Michael.
I don't think I've ever had a follow-up on a follow-up before, another unprecedented thing today. But I wanted to tell you a quick story. When we added post-traumatic stress as a qualifying condition to medical cannabis access laws across the country, we did that as a strategy starting on the West Coast and going to the East Coast. Very successful. Virtually every modern state law now has post-traumatic stress as a qualifying condition as a result of that. And we faced some big battles. Ironically, we were fighting against the American Psychiatric Association. I say ironically because they didn't, I was there for Prop 215 and many other state laws, and I don't remember ever seeing the American Psychiatric Association show their head. But the minute we tried to add post-traumatic stress as a qualifying condition under medical marijuana laws, boom, there's the American Psychiatric Association. Their longest battle was in Colorado, but the craziest battle was in New Mexico. One of their top guys, Dr. Ungerweiler, made a petition to remove post-traumatic stress as a qualifying condition. And I think his story is very telling because he came to this panel of experts and everybody on this commission to present his story, and it was completely hypothetical. And what was up against him was 300 people in the room that were all patients, caregivers, doctors, nurses, family members, and community members. And that was literally the only person there on his side was him. And when they realized on the panel that it was completely hypothetical, they lost some patience with him. But that's kind of where we're at. It's like I found it very strange, really, that they don't see, because I read some of their materials from the association, and they were at that time really trying hard to do a focus on the patient-centered care and be more responsive to the patient's, input while creating, treatment plans. And I was like, you're not listening. You're not listening. We're right here, and we're trying to tell you, and we're tens of thousands, hundreds of thousands, even at this point across the country. Are they hearing us?
Psych, for me, I think from what I see, is going to be one of the hardest doors to push open. on the weekends, I also work at another hospital with a different psychiatrist. And I'll just share this story with you. I had a Vietnam vet who was having severe difficulties on the unit. I work on a Jerry psych unit on the weekends. He was flipping out. He was throwing things. He was yelling, "I want my effing weed." Like, he was getting really upset. I got closer to him. I started to talk to him. I said, "Look," I said, "let's roll a virtual joint," right? So he stopped and he goes, "What are you talking about?" I go, "Look, like, let's sit down by the TV." I brought him over the TV, sat down. I said, "Look, let's roll a virtual joint. Let's like make believe we have a joint here." And he's like, "Well, I usually put it in a pipe." I'm like, "Well, you put it in a pipe. Like, that's fine. Let's just, let's chill out here. Let's act like you had some weed. What would you do with some weed right now?" The whole entire situation was de-escalated. There was no chemical restraint. There was no physical restraint. He calmed down. He took his pharmaceuticals and everything was okay. That was a Sunday. The doctor, the medical director, was on call that weekend. I told him what I did. He didn't say a word. 4 days later, I get a message from my nurse manager who says, "Nique, I need to talk to you. The doctor has concerns about your nursing." I said, "Why?" And she proceeded to say, "Because of what I just did to take that Vietnam combat veteran from a state that was triggered and hyper excitable, to sit down and roll a virtual joint with him with no intervention, no physical intervention. And I was chastised as he had concerns about my nursing, and proceeded to say, we work for a Catholic organization and cannabis is not allowed in this facility." Now, I'm big on perception. I built a whole program on perception. I just want to say this. I also had a patient recently who's an old school schizophrenic. She's in her late 60s, African-American, classic schizophrenic. They had her on 60 milligrams of Zyprexa. If Mary Lynn, you probably know, Zyprexa max dose is supposed to be 30. Some things say 40. They had this woman on 60. Does she have Zyprexa use disorder? Because guess what? I don't care if they went to 70 or 80 milligrams. Her tolerance was there. It's not doing anything for her schizophrenia, but yet we push these pharmaceuticals that cause all these other problems. So then we'll put the Zyprexa and then we'll add some Cogentin because she's having these movement disorders. And then we'll add some Ativan because the movement orders are stressing her out. So let's get her on some benzos, and then it's making her nauseous. So we'll give her some olanzapine. And I'm just like, but if you mention cannabis, they question the type of nurse that you are. But I don't care, because at the end of the day, there's reasons why I do this. And the bottom line is, I suffer from chronic suicidality. There's not a day in my life that there's not like this fleeting thought of like, what if? I have a plan. If I told that to my doctor, which I don't have, but if I told it to a psychiatrist, they would PEC me to the psych ward. But I always have a plan, because it just keeps me comfortable knowing that I'm in control if I really wanted to do it. But I see the injustices of the healthcare system. I see what they've done to me. I see that they've done to my peers. I see that what they do to the patients that I care for, but right now I have to pay my bills. So that's why I decided, while I'm paying my bills and my student loans, I can figure out how to disrupt the system. And if I can prove that what they're doing is wrong and what they're doing is not unjust and it's poor quality patient care, there's no facts. I've sat with the nurses, I've sat with the doctors, I've sat with the psychiatrists. They don't know anything about the endocannabinoid system. They don't know anything about cannabinoid therapeutics, and they don't want to know. So the next step is we have to find a way that they have to get the education. Why is it that they don't have to have cannabis education and endocannabinoid system education, but they have to learn about the new diabetes medication that's out, and they have to learn about the new antihypertensive that's out, and they have to learn about the new antipsychotics that we're shooting you up with once a month because that's keeping you stable. But yet they don't need to know anything about cannabis, nor do they want to. It's so disheartening, and I'll just go to my grave fighting for the rights. And the ironic part of this is that I don't even smoke cannabis. I can't. Weed makes me very paranoid. The most I can do is 2.5 milligrams. I use 2.5 milligram little cocoa at night to go to bed. I get very paranoid. So I will also fight for those who can't use cannabis, because there are negative side effects of cannabis that we do have to talk about. And there are some people that cannot use cannabis and could make them susceptible to a breakdown or something else that's going to harm them. But again, it's about the education. And the last piece I'm going to say about cannabis use disorder, and before somebody else has a question, is that I firmly believe, and I've seen it with the work that I do with perception, cannabis use disorder is not the end of the road. Cannabis use disorder with education can be a learned experience that somebody can go from inappropriate use to appropriate use if they learn how to use it, if they understand their endocannabinoid system, and if they learn what it does to their body and their psyche. And I don't totally believe in this whole cannabis use disorder and what they're trying to do to patients.
Thank you for your extremely eloquent breakdown of that, because yeah, it has so many layers, and unfortunately the willful ignorance, because that's really what it is, right? They're going to deny it because of what they've been told prior, and what they've been told prior was, when we go back and look, I have testimony from doctors back in the 1930s that the then FBN, Federal Bureau of Narcotics, came into their college, made sure that they were all there and in class, and while in class came in and had them rip out everything regarding cannabis out of their medical books and pass it forward for the FBN agent to take out of their colleges. So the Stockholm Syndrome, I think, is something we're not talking about, because of the stigma of the, the big boogeyman of cannabis, because we've been told the boogeyman is cannabis, but not necessarily using their own sense and judgment to realize that they've been duped through ignorance, and they're playing into that hand, unfortunately, because their peers and peer pressure here, and especially I saw Dr. Dodd McArea was my original doctor, so I watched him get absolutely railroaded and treated like something you would scrape off the bottom of your shoe, unfortunately, because he dare not only speak about it, then publish books regarding it, calling them out from their own research, and seeing the vitriol, the hate, the abandonment by the psychiatric people as a whole was frightening to see as a layman on the outside. And I could not imagine the experience it must be for those experienced like yourself on the inside to see these types of injustices, much less as you are feeling these types of injustices, it angers me as a patient to see that my doctors or psychiatrists have to struggle with this type of willful ignorance, as opposed to that Hippocratic oath that they were supposedly sworn to keep and uphold. Thank you. Thank you. Thank you. And as Michael Krawitz says, your work is extremely important to our future and what we've been working to and towards. This is another level that we have reached that has to Kilimanjaro, that has to be climbed to, you know, reach that summit, because there shouldn't be anybody dealing with the stigma that you're experiencing, nor should future generations. And hopefully, due to the ANA now making it a specialty, we will see a great deal of education around this as we see others create curriculum too. So what curriculum would you recommend to a psychiatrist, a young person like yourself that's going into psychology, you know, mirror image of you? What would you recommend them learn, research, or read up on, since, you know, currently there isn't a lot of, you know, known knowledge at that level? What would you recommend for them to absorb?
To be honest with you, Marilyn has been in this for decades, and she is much more versed to answer that question. She's been in the trenches and started the curriculum with this, and I wouldn't be where I am today if it wasn't for her and other nurses like her. And I need to give that shout out, and I need to put that recognition out there, because I remember in 2015 at my first Patients at a Time, when I was just finished battling my second battle with cancer and found out that cannabis nursing was a specialty. It was Marilyn who I met, along with Heather and Marcy. And, you know, I have to give the recognition where it's at. So I'd rather defer that question to Marilyn, because she has built the education and the criteria and so much out there to help other nurses and healthcare providers get what they need.
Mary Lynn, do you wish to respond at this time? Nurse Yoda.
Yeah, well, of course, I'd say Patients at a Time conferences, ACNA conferences, CNN conferences, Cannabis Nurses Network conferences. I mean, they're all putting out really good information these days. It's funny though, because same here. I'm at UVA, University of Virginia, trying to get something into the curriculum or whatever, and it's legal in Virginia. I think we got a new dean again and a new director of nursing. So I'm trying to meet with them. They wouldn't meet with me, so I wrote them together. You know, both of them. Can I meet with you jointly? And so I met with them about 2 months ago, maybe. Brought in all the books, brought in the Journal of Nursing Regulation that from the state boards of nursing that, as we know, is setting standards and all this stuff. Try to say this is real, and it's legal in Virginia, and patients are using it, and your staff know nothing about, you know, blah blah blah. And after about a half hour or something, they basically told me they appreciated my passion in the issue, but that's it. So then I just left it with, okay, well, I'm going down to Australia to present at their national conference on cannabis. I'll come back, you know, I'll, you know, let you know what I learned down there when I come back. And now I just wrote them yesterday, sending in the ANA. It's a specialty now. Do you think maybe we could get it into the curriculum? Do you think maybe we could teach the nurses? But it is so frustrating. It's the intimidation of the institutions that are just, you know, their little thing, oh, we'll get shut down by the federal government if we allow cannabis. And it's like, no, you won't. You really won't. But yeah, there are a lot of good courses out there, and what nurses want are accredited courses, as you know, and I think that's what everybody that I named, you know, whether it be, I shouldn't say Patients at a Time anymore. For me, I will pass the baton to the Academy of Cannabis Education. We'll be continuing the series that we started. And the plug early now is that we're looking for the spring in Charlottesville next year for the next one.
I do want to add that I recently was appointed the vice president of Sigma, which is an international honor society for nurses, the Rhode Island chapter. And part of what I had to do for my first task was I had to put together a fall program. And I had to go up against all the board of directors, and they all gave their thoughts on what we should do. And I said, how about if we did a presentation on cannabis? I said, we're in a medically legal state. I have multiple cannabis nurses. I can put together a panel of different specialties in nursing that all use cannabis from experts in cannabis nursing. This includes the University of Rhode Island, Salve Regina University, and Rhode Island College. All of the board members agreed 100%. They allowed me to move forward. I put together a 2 CEU presentation. I have 4 nurses from the Cannabis Nurses Network that are coming from different areas to present on this panel. And it's going to be October 19th. And not only did Sigma allow us to do it at the New England Nursing Education Center in Rhode Island, in Providence, Rhode Island, but if we're still waiting on the CEUs, if the CEUs get approved, Sigma is also allowing us to videotape it, and we are going to be able to put it on Sigma International site and have it there for a year for those nurses and nursing students and educators who want to learn more about nursing, about cannabis nursing. So I felt that that was a huge win, especially because I failed out of multiple nursing programs. And here I am sitting as a vice president in a international honor society. So again, you asked about the Marine Corps Foundation that I have. Like, it's that just, if you tell me I can't, I'm going to. So I'm really looking forward to that and seeing what that does for the shift, because I'm also right here in Providence. We have Providence College just started a nursing program. Johnson and Wales just started a nursing program. And we're also right next to Brown University and some other institutions. So I'm hoping that, as they say, as we keep trying to plant a seed wherever we can, we just need one person to let us in and then just take it from there.
Councilmember Mathry, Marilyn.
Yeah, more than call on me, and it was like, what the hell was I gonna say? I think I just blanked on it. Oh, I know what I wanted to let you know, Nique. Melanie Dreyer was the president of International Sigma Theta Tau in 2004. No, somewhere around in the early 2000s. I'll have to let her know you're doing this. She'll love it.
Great.
All right, we will get to our next question, which will be from your friend, Councilmember Michael Green. Councilmember Green, you're recognized.
Hey, first and foremost, Nique, it is so good to see you. Sorry I missed you last week, so it goes. You're like a one-woman battalion. You're amazing. I mean, I've talked to you a number of times over the years since 2015, but what has come out this evening, I've heard the truth. I've heard the difficulty. I see your passion. Keep up the fight, lady. I mean, I would have given you a fucking medal for what you did in that psychiatric unit. Absolutely. And then before I forget, I'd be more than happy to participate in your study. And there may be other council members that might want to do that and share. I guess we would have to talk about a constable. For myself, I would love to participate in your study. I'd be more than happy to contribute. Absolutely. And just as Michael Crowwood said, thank you for your good work. It's amazing. And I'm blown away, truly. My question goes to medical cannabis. We know culturally that people have been relying on the medicinal properties of cannabis for thousands of years. We also have had pharmaceutical, so cultural thing, folk medicine, whatever you want to call it, homeopathy. People self-medicate. But we also know in recent years, there's been developments in the pharmaceutical industry. What comes to my mind is Marinol, Epidiolex, and was it Sativex, if I'm saying that correctly,
Mhm.
which is not, I don't think, approved in the United States, but nonetheless, pharmaceutical compounds or extractions, whatever, they're medicinal. From your perspective, how do you see the future of these two different threads, maybe commingling or failing to commingle to, to work for treatment and medical access to cannabis?
Well, again, I'm kind of limited because my specialty is psychiatry.
Yes.
So in the world of psychiatry, it is a little bit difficult, but I do know that on one of the Jerry psych units that I work at in one of the larger hospitals, because I have a few different jobs, we did have a geriatric patient that had failure to thrive, and I was able to convince the treatment team. The charge nurse was put forward to the doctor to start the patient on Marinol. So I did see that happen. And I'm actually going to work with Dr. Perlson on working on a protocol for cannabis withdrawal in the hospital, and possibly use, like Heather said, Marinol or one of these other cannabis derived medicines if they will approve it. So that way we're not using pharmaceuticals for this, or find a pharmaceutical that's very benign. Like I know with some of the addictions, and Mary Lynn, you can speak to this better than me, they use clonidine. And that, and Eloise, one of the cannabis nurses, was saying that they're using Neurontin for cannabis use disorder. Like, I can't believe they're using, which is also gabapentin. So I'm trying to be very cautious about how I do this, because once it gets into some of the psychiatrist hands, they're going to turn it into like a CEWA protocol or an alcohol or protocol or the opiate protocol, where they're going to have, like with alcohol, your Libriums, your Valiums, your Suboxones, your Methadones. Like, I'm trying to dance lightly around this so that way cannabis withdrawal doesn't turn into like this other addiction and they see, I told you so, so it's hard to say where it's going to go with all of that. I don't see a lot of it right now at all. Now on a medical floor with different populations, maybe in psych, I don't see it.
Thank you. Thank you for your answer and in being honest about what you're comfortable with addressing and not. I really admire you. I salute you.
Thank you.
Thank you, Michael Green. Next up will be Council Member Mary Lynn Mathry. Council Member?
This is funny because the last question, do you see a future where psychiatry and cannabis merge?
I do.
Future.
I do. As a matter of fact, in the Olin Neuropsychiatry Research Center, we just finished up a study that I was the substitute investigator for Dr. Perlson, in which we were using 600 milligrams of CBD versus a placebo to see its effects as positive effects on psychosis. So we're waiting to look at that data and see what that looks like. But so far it looks very promising. And that was a small pilot study. So possibly we will get a larger population. I'm not sure what the future of that study is, but I know we're seeing promising effects with psychosis and CBD. Also too, we are finishing up right now a study with THC and memory, and we use THC or a placebo. We have two age groups, 18 to 35, and our other age group is 60 to 75. So that study is not done yet because there's specific age groups and it's a lot harder to get our participants, but we're dosing them. They come in for 3 visits. The second and third visit is a dosing visit. The first, we don't know which is which, although you do know what a THC or a placebo is. You can tell when somebody's smoking THC and when somebody's smoking a placebo, but they have the, we use a volcano. I'm administering THC with a volcano. I dose them with a volcano. Prior to that, I'm putting in an IV so I can draw blood. I draw blood at different increments, and we're looking at THC and memory. They're going in an fMRI. They're taking tasks while they're in the MRI. So we're getting brain images to see what THC is doing to their brain. When they're done in the MRI, then they go to an EEG, a 64 lead EEG. We put the cap on them. They go through tasks while they're in the EEG. And that's the data that we're collecting right now on human studies with Dr. Perlson. So we can say, and Dr. Perlson is a neuropsychiatrist. So he's internationally known for his work in schizophrenia. So we're really trying to change the envelope of what psychiatry and cannabis looks like.
Very good.
Councilmember Green had a follow-up.
Yeah, I wanted to mention in passing, because you've mentioned Dr. Perlson a number of times. He put out a beautiful book about a year and a half or 2 years ago, perhaps now, Weed Science. I would highly recommend it to anybody in our audience. And then it occurred to me, saying that, I believe both you, Nique, and Mary Lynn are featured in volume 2, Encouraging Cannabis. And so thank you for that as well. And I would also recommend Encouraging Cannabis, where our friend Dr. Bridget Williams, who appeared on the show some months ago on the Roundtable, was the primary mover and editor of. Just wanted to share those things. Thank you again.
Thank you.
Well, thank you, Nurse Nique, for taking the time this evening and answering many questions and enlightening people about your work and the work that you've been working to and towards. It is very important work, and please come back in the future and check in with us. We'd love to hear from one of our own, because part of V.A.C, we're volunteer veterans just working at the national, international, and local level. So having educators like yourself who are trying to take things to another level, let us know if there's anything that we can help and assist with in the future. Needless to say, I can't thank you enough for taking the time. Councilmember Mathery?
Yeah, Nique, in terms of your study, when you need, if you need veterans or something to answer that, is that something that's like online, or you don't need them locally in Massachusetts?
No, once I have this survey up and running, it's just a survey link. So I need a minimum of 250 people to take the survey. So
We
that
can help spread the word.
Yeah.
that would be really awesome, because to really collect the appropriate data, I need a minimum of 250 participants. And as you know, it's hard to get people to take a survey. You think it's easy, but like even myself, sometimes I'm like really overwhelmed and busy, and I see a survey come through and I feel bad, but depending on how long it is, sometimes I'm like, oh, I can't do that right now. But I mean, as soon as we get it up and running, which I hope it's by the end of October, that it's at least in the hands of the IRB at Hartford Hospital. That's my goal for myself. And because I've already submitted the grant application, it shouldn't be that hard to switch it around to the IRB application, especially because I'm not asking for any money.
And that's key.
Exactly.
You wish you success and luck there, but we're also happy to lend our mailing list to help you out. So we're here to help you. Councilmember Prowitz.
Yeah, our council member from UK reminds us that the psychiatrists that he's working with in the UK predominantly get it and are working on the evidence base, not following whatever NIDA fact sheet or whatever it is that's leading around the American psychiatrist. So I don't know. That would be an interesting one if there's just some sort of international cooperation that might do something to help in this regard.
Pius, did you have a question specifically for Nurse Nique since you were able to pop in from England?
But unmute.
Pius? We cannot hear you, sir. Your mic.
Can you hear me now?
There you are.
Sorry, went onto a different microphone. Now, I was saying not necessarily a question as such, but I was just commenting that I myself have a prescription for cannabis from my psychiatrist since they legalized it here in 2018. So rather than being like a recommendation, it's like an actual prescription. But I guess from a patient standpoint, as a nurse, I believe that nurses are the ultimate patient advocates and believe in that very strongly. What can patients learn from you in terms of safe use of cannabis, especially in patients who have psychiatric conditions? What would be your recommendations?
That's a great question. And again, I'm not a nurse practitioner. So from the patient side of things, because I am a patient, I've learned because of my sensitivity to THC that when they say go slow and dose low, I really mean that. When I say 2.5 milligrams is what I use. Some people say, oh, start low, go to use 10 milligrams. 10 milligrams, like somebody for me, is too much. Don't feel embarrassed if you're only using 2.5 milligrams, because what you can do is you can break it down and you can, so say you took 2.5 milligrams and then in like a Tylenol, right? In 4 hours, take another 2.5 milligrams if you're looking for a certain effect. I think what it is, you have to build a relationship with the medicine, with the plant. And you really need to ask yourself, what do you want it to do for you? What are the symptoms that you're trying to treat? What is it that you're looking for help for? So when I first started, it was for sleep. And it was for the anxiety and nausea of my cancer treatments. So I didn't need to smoke all day, every day, and I couldn't smoke all day and every day. I think it's individualized care, and that the one thing that I love about cannabis is that you're able to guide and lead your own journey with the plant. So you don't have to ask anybody what it is that they're taking. You yourself will be able to adjust it as needed for the effect that you're trying to get. And I think in the cannabis world, we call it the sweet spot, and everybody has a different sweet spot. But once you find that and find what works for you, it can change the direction of your life.
Absolutely. I said self-titrate for the win. And that's one of the things that is great about cannabis is everybody's level is different. On top of that, what works for me won't work for you. And that is another thing we've had to make patients very much aware of. And dosage is such the key. We're very fortunate to have medicinal access here in California, and one of the great entries is a 1 THC to 20 CBD, which is a wonderful simple tea in a tea form, so that when I wanted my mother to try cannabis for her later in age life, it was an easy access point for her. It was comfortable, it was familiar. She wasn't going to smoke anything. So I look forward to also the new grounds that are broken for ingestibles and different ways of ingestibles from the transdermal patches, etc. Because people seek the relief, but they're not seeking the high, which is something that we are aware of, medicinally, but many people, their only experience with it is getting high. So they don't understand that, what and where that is. So Thank you for being an educator to help people along the way that we can hopefully arrive there collectively in time. So again, your work is so important, and we appreciate the risk you're taking, as well as your passion there, soldier. We have great respect for one of our own climbing other ranks and establishing their own beachhead in life. And you have done so with great respect and integrity. So carry on your path. Thank you. So
Thanks,
thank you,
ASL.
everybody. This will wrap up. Do you have anything to promote, Nurse Nique? Anything coming up that people should be aware of? Any publications or how to get hold of you?
So you can find me in volume 2 with Mary Lynn, Encouraging Cannabis, a book that was put together by Dr. Bridget Williams. My website is getting revamped, but it's still available as is right now, which is positivelyprocessingperception.com. And if you can change your perception, you can change your life. And with that being said, every other Wednesday, so I just had one this Wednesday, so it won't be next week, the week after. There's a link. I have a Facebook page called Positively Processing Perception, and there's a link to a free workshop that I do every other Wednesday. And it's to have people come together, and I have an object of perception or words. And a group looks at this and we show how everybody has a different perception of the exact same thing. And it's very powerful, and it's transforming, and it's a journey of self-reflection and healing.
Is that?
It's Positively Processing Perception. It's on, I have a Facebook page called Positively Processing Perception, and you'll see an event link for every other Wednesday night, and it's a free workshop. There's, you never know who's going to be there. Sometimes there's 4 people, sometimes there's 10 people, and I pop up something that we all look at. And it's amazing how we all have a different perception and interpretation of the very same thing.
Again,
Oh,
thank
yeah.
you so
The
much.
doors to perception.
Well,
So is that next Wednesday or the following Wednesday? Did we just miss?
So I just had it this week. Everybody just missed it this week. So it will be, let me look at my calendar. So the next one would be October 11th.
well, there we have it, ladies and gentlemen, October 11th for the next Positively Processing Perception. Again, Nurse Nique Pichette, thank you for joining us for our V.A.C. Roundtable number 62. I would like to thank our members, Michael Green, Alex Popoff, Wade Laughter, Marilyn Mathery, Michael Krawitz, Nate Landau, and our friend over the pond, Pius, and myself, Etienne Fontaine. Thank you all very much for V.A.C. Roundtable number 62. We'll see y'all. I think we're going to take the next one off, so we'll see y'all in a month. So thank you much, everybody. Have a great rest of your night.
Thank you so much.